Today we will be discussing about chondrosarcoma. So I am reading this paper on chondrosarcoma. Chondrosarcoma are a malignant cartilaginous neoplasm with diverse morphological features and clinical behavior. They account for about 20% of all primary tumor of bone and usually arise in pelvis or long bones. Primary or conventional chondrosarcoma arise in the pre-existing normal bone and is distinguished from the rarer secondary tumors which occur within a pre-existing chondromas or osteochondromas. And this activity review of chondrosarcoma and the role of interprofessional team in recognition and management of this condition. So chondrosarcoma are a malignant cartilaginous neoplasm with diverse morphological features and clinical behavior. They account for 20% of all primary malignant tumor of bone. They usually arise in pelvis or long bones. Primary or conventional chondrosarcoma arise in pre-existing normal bone and is distinguished from the rarer secondary tumors which occur in pre-existing enchondromas or osteochondromas. Conventional chondrosarcomas, which account for 85 to 90% of the chondrosarcomas, are divided into central, periosteal, and peripheral subgroup. So, non-conventional chondrosarcoma variants include clear cell chondrosarcoma, mesenchymal chondrosarcoma, dedifferentiated chondrosarcoma. The radiographic feature of chondrosarcoma are often very characteristic, and definitive diagnosis can usually be made by imaging. So what are the etiologies? They are sporadic but may develop from malignant transformation of osteochondromas or enchondromas, and malignant transformation occurs in 5% of the osteochondromas, either multiple or solitary forms. Epidemiology: primary central chondrosarcoma is the third most common primary malignancy of the bone after myeloma and osteosarcoma. Chondrosarcoma is a tumor of adulthood and older age. Majority of these patients are older than 50 years of age with a slight male predominance. The most common location of involvement of the chondrosarcoma include bone of the axial skeletal, that is pelvis, scapula, sternum and ribs, followed by proximal femur and proximal humerus. Involvement of hand and feet are rare. Pathophysiology: chondrosarcomas detected in some type of chondrosarcomas. Chromosomal anomalies can be detected like 9p2110, 13q14, 17p13, and chromosomal structural abnormalities and genetic instability are reported in well differentiated chondrosarcomas analyzed by cytogenetics. The amplification of MYC and AP1 transcription factor plays a vital role in the pathogenesis of chondrosarcoma. Histopathology: macroscopic findings. Chondrosarcomas are large tumor, usually larger than 4 cm, and they have a translucent lobular blue-gray white cut surface corresponding to the presence of hyaline cartilage. They may be areas of containing myxoid or mucoid material and cystic changes. Yellow-white chalky areas of calcium deposits are commonly present, that is mineralization. Erosion and destruction into the soft tissue may be seen. And on microscopic features, there is abundance of blue-gray cartilage matrix production. Irregularly shaped lobules of cartilage varying in size and shape are present. Fibrous bands separate these lobules or permeate bony trabecules. Calcified areas suggesting the presence of a pre-existing enchondromas can often be found. Chondrocytes are atypical and with variable size and shape contain enlarged hyperchromatic nuclei. Binucleation is frequently seen. Chondroid matrix liquefaction or myxoid changes are common feature of chondrosarcoma. Necrosis and mitosis can be seen. There is often permeation into the cortical bone and the marrow space with entrapment of bony trabeculae. Grading of chondrosarcomas is essential and is useful in predicting histological behavior. Chondrosarcomas are divided into three grades. Grade 1 considered to be low grade, locally aggressive, also called atypical cartilaginous tumor. Grade 1 lesion often closely resembles normal cartilage or benign enchondromas. In this instance, the distinctions between benign and malignant often depends on the demonstration of the chondrosarcoma permeation pattern, where the tumor infiltrates through the marrow cavity instead of being confined by the native architecture. Grade 1 chondrosarcomas are moderately cellular and contain hyperchromatin plump nuclei of uniform size. Grade 2 contain greater degree of nuclear atypia and nuclear size and are more cellular, mitosis can be found. Grade 3 are more pleomorphic, atypical than grade 2, and mitosis are more easily detected. Cells in the periphery of the lobes are less differentiated and become spindled. So the fourth group of chondrosarcomas combined as grade 4 is called dedifferentiated chondrosarcoma, make up to 10% of the chondrosarcomas, and this dedifferentiated occur in a small subset of patients and is defined histologically by the presence of high grade, often spindle or pleomorphic tumor without significant cartilaginous matrix. Dedifferentiated chondrosarcomas by definition are high grade neoplasm with an inferior prognosis. Other less common types are mesenchymal and clear cell chondrosarcoma. IHC, only a small percentage of the IDH1 mutation, that is 20%, can be identified in a specific IDH1 R132H antibody. Symptoms usually long duration and can cause located in the skull base, can cause neurological symptoms. So plain radiograph, they show X-ray identification of the cartilaginous nature and aggressiveness of the lesion, and plain X-ray may reveal lytic lesion in 50% of the cases, intralesional calcification in 70% of the cases, endosteal scalloping, permeative appearance or moth-eaten appearance of high-grade chondrosarcoma, cortical remodeling, thickening, and periosteal reaction. CT shows matrix calcification in 94% of the cases, endosteal scalloping, cortical bone in 90% of the long bone chondrosarcomas, and heterogeneous contrast enhancement. MRI typical form, MRI demonstrated lobulated lesion with a high signal intensity or T2 and low intermediate signal intensity on T1. Tissue biopsy should be taken for more aggressive portion of the cancer as determined by imaging. Treatment, surgery according to the location, histological grade, and the primary treatment modality surgical excision, and low grade can be treated with intralesional curettage, burying, and surgical adjuvant applications such as hydrogen peroxide. And larger tumor can be treated with wide excision. So chemotherapy not efficient in conventional chondrosarcoma, but there is some role in dedifferentiated chondrosarcoma containing high-grade high-grade spindle cell component. Radiotherapy is indicated to improve high local failure rate and include locally recurrent tumor intermediate to high grade and tumor in locations where surgical resection is challenging. The differential diagnosis is chondromyxoid fibroma, anchondromas, chondroblastic osteosarcoma, fracture, callus. Prognosis, so histological grade, that is the single most important predictor of local recurrence in MATS. Low grade chondrosarcoma which grow insidiously and rarely metastasize have a good prognosis. The 5-year survival rate of grade 1 chondrosarcoma is 83%. High grade chondrosarcoma, dedifferentiated chondrosarcoma by comparison have an inferior prognosis due to rapid growth of tumor and propensity for early mets, and the 5-year survival rate of grade 2-3 chondrosarcomas is 53%. Complication, recurrence of the tumor, distant mets, site is lung, and the rare metastasis occur varies according to the grade of the chondrosarcoma, like metastasis in low grade is less than 10%, intermediate grade is 10 to 50%, and high grade is 50 to 70%. Thank you.